So welcome to this session on the Housing First philosophy. This is the second session in our little series here. If you didn't make it to the last session, we did a session on an intro to harm reduction. That was fun from my perspective. Definitely, you're a different sort of group for us to speak to, and different sort of questions came up, which I love. It was fun to engage with that. Um, if you're new to this session, if this is your first time seeing my face, I just want to quickly say my name is Ryan Villagran. I'm a training specialist at an organization called Pathways to Housing PA. And we do housing first work here in the Philadelphia area. We've been doing that since 2008. And my job in particular is to share that work and share best practices of that work out to organizations across the country. Um, and so as you all are embarking in a very exciting chapter of becoming a housing provider, wanting to share some tools with you about what this could look like, be able to answer questions that you may have about kind of your relationship to the project and potential relationship to your new neighbors as that moves forward. So wanting to share with you from our perspective as a housing first provider, what this can look like and what you can expect to see. We've tried to slim back a lot of the language in our presentation that maybe is really much more geared to social workers. We tried that last session too, and we still got feedback that it was pretty social worky. So I expect probably the same will happen, but I would invite you to let us know in the chat or raise your Zoom hand and say, I don't know what you're talking about. That doesn't make sense to me. And we'll do our best to try and explain it. But really, this session is about the principles of Housing First and why we think it's an amazing tool to end homelessness for so many people. So that's me. That's Pathways and Housing First University. I want to kick it over to my co-presenter to introduce herself, the amazing Christina Scalia-Jackson.
Hi, everyone. My name is Christina. I am the director of our Center of Excellence for Opiate Use Disorder. So at Pathways, that is another community-based care management team that helps support those who have specifically opiate-related needs. I've been at Pathways now for about 4 years, and before that, I interned on the healthcare side. So I am pretty familiar with the Housing First philosophy. So I hope I can answer any of your questions tonight. Feel free to jump in with your hand up or comment in the chat, and Ryan and I will try our best to answer questions as we go along.
Yeah. Some quick housekeeping, just inviting folks to be present with us. I know that's not a challenge for this group. You all are so engaged the last time. We, again, do speak to people during their workday often, and it's very easy to see that they're multitasking, which is fine. We're just not engaged in as fun of a conversation. So if you're able to be with us and be present, it'll be more fun for all of us. That chat box is open. I'm going to type something in the chat box now so you can see that pop up. And if you want to chat at any point during today's session to ask a question, don't hold your questions, don't hold your comments into some Q&A period at the end. Would much rather see that pop up. If you're having that question right now, somebody else might too. We are able to offer certificates of attendance. That may not be important to you, but the way that you could achieve that certificate is by simply completing our course evaluation at the end. And even if you don't need a certificate or want one, we strongly encourage the course evaluation. It helps us understand whether we have met your needs and whether you have additional questions or additional comments that struck you as we ended our session. We are going to take a little break in the middle of the session, about halfway through, and then we are going to make these materials available to you following the session tonight. We tried to make this a visually and audio accessible session. So if closed captionings would be helpful to you, there is a way to press the show captions button and you'll see an auto transcript kind of populate as we go. We're going to attempt to read aloud questions and comments from the chat. So if you're kind of following along in an audio way, hopefully that'll be accessible to you. And we've tried to make high contrast text and background so it's visually accessible. If there's anything else we can do to help you as we go, please chat me privately and I'll see what I can do to help you meet your learning needs tonight. All righty. I'm going to close my door because there is some loud cleaning happening outside. Excuse me 1 second. Okay. So here is our agenda for tonight. We're going to talk very briefly about the history of the Housing First model. It's been around a long time, and I want you to be aware of that and where it's coming from. We're going to talk about why Housing First is needed. Certainly, there are a range of services available to people experiencing homelessness. This is one tool in the tool belt, and we think it meets a very specific need. And so we want to share a little bit about that with you. We'll talk about the 5 key principles. In our line of work, everybody purports to do Housing First. Everybody is not doing Housing First. And so we want to kind of center ourselves on some principles that we hold very dear to let us know that we are adhering to Housing First as it was intended to be. We'll talk about some of the benefits and challenges we can expect in a Housing First setting. We'll compare that briefly to maybe a more traditional housing approach. We'll talk about what it could look like to initiate services, and then we'll probably wrap up with some Q&A at that point. Last session that we had, we did 3 hours. We're going to do 2 hours tonight. Keep it nice and tight. Get you in bed on time and me. So we'll move a little quicker tonight. Here's our learning objectives. By the end of the session, we want you to be able to recognize barriers to housing stability for folks with disabilities. We want you to be able to identify those 5 key principles that we talked about. And we want you to be able to explain the benefits of Housing First versus traditional recovery-based housing models. I think you all are making a very intentional effort to kind of move in a Housing First direction and partner with an agency that is using a Housing First approach. And I want you to sort of see a bit about what you're avoiding or the direction that you're choosing as you explore Housing First. So as an intro to Housing First, one way that we sometimes talk about this with folks, because Housing First is such a buzzword out there, we sometimes like to be a little specific about how we practice Housing First and how others might. And so Housing First with the capital H and capital F, this is an evidence-based practice model that we use here at Pathways. And when I say evidence-based, what I mean is that there are 30 years of research that have followed high-fidelity Housing First programs that follow the program manual to a T and have achieved a certain degree of outcomes that are repeatable, they can be replicated in research, and are successful. Right? So that's what high fidelity Housing First is. There's these 38 fidelity measures that a program can say, are we doing this? And they can answer that question, yes, or sometimes, or not at all. And we have done that ourselves. We've done our own internal review. Actually, we partnered with a consulting firm to sort of conduct our own fidelity assessment and say, are we doing Housing First the way it's meant to? And I think we discovered that we were, and our outcomes matched that. Another core part of Housing First is that it includes a case management team that wraps around supports around folks. And so what you might see in a Housing First program are a whole team of workers from various parts of the healthcare spectrum. We've got nurses, a psychiatrist, perhaps a behavioral health therapist, case managers with various specific target focuses, like folks who focus only on people who are involved in the criminal justice system, folks with medical challenges, right? So that whole team wraps around a group of people. On the other hand, you have what might be called Housing First or a Housing First approach. This is mostly what people are doing out in the social services world when they talk about Housing First. Most programs are not using that really high fidelity model. But it's very similar. It uses those 5 key principles, which we'll talk about. It tries to lower barriers to entry for folks. One big thing that we talk about a lot in this field is that the barriers are too high for people who are vulnerable, right? To vulnerable groups. They are experiencing challenges with their mental health or their substance use or medical challenges. And in order to access the services that they need, they're running into barriers, often bureaucratic barriers, eligibility barriers, and are not able to be successful for some of those reasons, right? And so here we're talking about lowering those barriers, meeting somebody's basic needs first, in other words, that housing need, and providing wraparound supports. So in essence, very similar to what I just described before, but without that close adherence to the model. So let's talk about what Housing First is. I said it's an evidence-based program model. I'm saying it again. I'm saying it over and over again. But what we're really aiming to do is assist folks who are experiencing chronic homelessness. Christina will tell us a little bit more about that moniker of chronic homelessness. But these are people who have been living on the street for some length of time. These are not the folks necessarily who become homeless for the first time. They go into shelter, they save up some money and get back into an apartment, right? These are folks who have been on the street for some length of time. And they have a severe mental illness plus or a substance use disorder. Here at Pathways to Housing PA, I think we're one of the first programs in the country who uses this like scattered site model that we use. In other words, people get their own apartments throughout the city with people with a primary diagnosis of an opioid use disorder. Typically, what you'll see in a Housing First program are people with mental health challenges who also drink or who also do some drugs, but primarily mental health challenges are the focus. But there are a whole range of people experiencing long-term homelessness who their primary challenge is substance use disorder. And so we think the program can work with both of those groups. You're also going to see in a Housing First program offering a rental subsidy for permanent housing. So we're taking a subsidy, and in our case, we're using subsidies from the Department of Housing and Urban Development, right? So these are federal subsidies that pass through the city of Philadelphia to put people in open market rental units, right? So just like some of us may be renting from a landlord, Pathways will rent from a landlord, and then pass along that subsidy to that landlord. I see somebody coming off mute. I'm going to go ahead and mute anybody who is not muted right now, just so we don't hear you moving around too much. Cool. I just got a private note, by the way, that the social service provider that you're going to be working with, A Roof Above, does focus on chronic homelessness, and that includes any disabling condition. So not specific, I guess, to severe mental illness or substance use disorder, but a broad range of disabling conditions. And yes, that chronic homelessness piece. So that makes a lot of sense. Another component of a Housing First program is that there are no preconditions or barriers. And specifically what we mean here is we're not asking people to be engaged in any sort of treatment program, job training program, medical care, whether that be treatment program around mental health or substance use challenges. We're not asking people to sort of get themselves right first before coming inside, right? And this is why it's called Housing First. All that other stuff, all those treatment challenges that could be dealt with, those come later in a Housing First program. And so we're not wanting to put preconditions of their entry into our program up front. We don't want there to be barriers. They've experienced enough barriers living on the street and their arrival in homelessness that we want to remove as many of those barriers to care as possible, right? And so there are really very few eligibility requirements in a Housing First program. Another key component is that there's no predetermined endpoint. So for us, what that means is that people may be living with us for the rest of their lives. They may end their lives. Hopefully it's long. Sometimes it's less long in our care, right? In the apartments that we're helping them rent and with the support of that wraparound team. Now, it is possible that people do exit a Housing First program successfully. And so what we sometimes see is people do so well in their unit for such a nice long period of time. We get them connected to other care supports in the community, and they don't need us anymore. And we think that's really quite beautiful. Those are our huge success stories, and we'll get them onto a different type of voucher that's unrelated to our services and enables them to live long-term in their apartment without us anymore. And so that's the key. It is possible for people to end a Housing First program successfully, but we're never going to predetermine when that should be. A Housing First program would never say 5 years until you get on your feet and then it's time to move on, or 10 years or 2 years, right? No predetermined endpoint. I've said this quite a bit already, but just re-emphasizing that it is not a housing first program without wraparound supports. And I do think we sometimes see in the media or people maybe less knowledgeable about housing first that will say, well, housing first is housing only, or you're setting people up to fail. And I think that couldn't be further from the truth, right? Without that wraparound supports, it is simply not housing first. Sometimes what you'll see is perhaps a housing provider, and I think this is somewhat similar to your circumstance, who partners with a social service provider. But that partnership is key. That's what makes it housing first, right? Um, Without those case managers checking in with people, seeing how the apartment is going, seeing how their living is going, are they taking care of themselves? Do they need anything? Without that, it's not housing first. Let me pause there. Any questions so far? Questions, comments, or thoughts? I want to let you chew on this a little bit as we go. If not, that's okay. I just want to keep making space. Don't want you to feel too nervous to interrupt. All right. So let me tell you very briefly about the history of Housing First. The Pathways to Housing model, as we call it, was founded by Dr. Samson Barris in 1992. And he was a clinical psychologist in New York City who saw people kind of languishing in long-term psychiatric hospitals. And he said, these people can be successful in the community. Now they're going to need a lot of support. And that's where that wraparound services piece comes in, right? I'll say that this model itself, the Pathways to Housing model that we follow, has been in operation in over 150 US cities. They're using it in many countries. More recently, I'm hearing a lot about Finland, who the kind of language that they use is like functional zero of homelessness, meaning people do become homeless, but it's very short stint, and their services kind of kick in to sort of help people rise up out of that, where they don't have sort of a chronic homelessness problem. Other cities that we're hearing a lot about lately are Houston, who has kind of a long-running program that's been really successful. Denver is another really successful example of Housing First being used to really make an impact on their population of people experiencing homelessness. As for us, I said that we've been in operation since 2008. There are also two other pathways in existence, the Pathways Vermont and a Pathways DC. Now, Pathways DC is going to look very similar to Philly's program. It's an urban setting. Many of the same challenges that they're dealing with, we're dealing with here. Pathways Vermont looks a little different. It's much more rural, of course. Making a home visit in Vermont looks very different than making a home visit in Philadelphia. All right. So I want to kind of start to invite your input now. I'd like to ask you this question on the screen, and if you want to raise your Zoom hand and shout things out verbally, or if you'd like to type in the chat, my question to you is, what stereotypes might we have about people experiencing homelessness? What have you heard? What do you see in the media? What do maybe we ourselves carry in terms of stereotypes about people experiencing homelessness? Would love to hear your input here. I see people
think I
type in.
hear that people like that are scary.
People experiencing homelessness are scary. Yeah. Um, Pat notes it's their fault, right? Or maybe they're not trying hard enough. They're lazy, they don't want to work. Mental illness, of course. Yep. Maybe they're dangerous. I think to echo that comment about scariness, right? Um, Lori notes they're homeless because they have an addiction. That's the reason they're homeless. Yeah, these are good. And these are very commonly kind of, this is very common what you're describing. Oh, Donna mentions they're criminals. They must be criminals, right? Um, Maybe they have mental illness, schizophrenia, perhaps dementia, bipolar disorder. Certainly that they're unemployed. Yep, thanks for sharing that, Jane. Yeah, these are good. And so I think you all have really touched on a lot of the tropes, and that we have this idea in general that people will become homeless because they're either lazy or they're crazy. And much more frequently these days, we hear this idea that they're drug addicts also, right? And so there is this idea, this thing that we want to sort of oversimplify the causes of homelessness by attributing it to a personal choice, right? Realistically, homelessness can be caused by so many things. We know that there are many environmental factors, such as housing costs or the lack of housing availability. There's a report that I like to read regularly called, there's two reports. One is called the GAP report and one is called Out of Reach. And these reports kind of show us that among the lowest income folks in the United States, there's a gap of around 7.5 million affordable housing units. And so there simply are not enough units priced at a range that the lowest income among us can access, right? And then relatedly, the wages that are being paid, you know, if I were to work full time at minimum wage, I would not be able to afford an apartment of my own at the median sort of cost in the United States. I would have to work over 100 hours a week at minimum wage to afford the median cost of housing in the United States, right? So housing cost is huge. The lack of housing availability is huge. And when we think about what I would call structural factors of homelessness, certainly there are neighborhoods, maybe you know some in your area, that have become disinvested in over many, many years, right? Well, what happens to those places with really low property values? We have developers come in, scoop up a bunch of properties, raise the price on them, and it starts to push people out of the neighborhoods that perhaps they and their families have lived for generations, right? So that gentrification process is another big kind of cause of the affordable housing crisis. We know that decreased job options, lack of a living wage for many jobs, and simply the history of racist and exclusionary housing policies are some of the factors that contribute to homelessness. These are environmental in nature. We also know that there are individual factors that contribute to homelessness, right? Folks do indeed have severe mental illness. Folks do indeed use substances, or may have cognitive impairments, or chronic health conditions, or various traumas that they've faced. Thinking about folks who have experienced interpersonal violence, and that being a contributing factor to their homelessness. What about also the folks who are returning from military service? Maybe they started using drugs in the service or felt inadequately prepared for a return to civilian life, right? Certainly when I think about mental illness and substance use, one of the big differentiating factors on whether somebody will become homeless or not, is whether their family is able to support them through those times of crisis. And whether or not those family ties are broken as a result of those challenges, right? I see Felicia adding in the chat, mass incarceration has created an undesirable tenant population. Thanks for sharing that, Felicia. If you could add any more to those thoughts, I would love to hear it. One thing that I do know is that when a person has experienced an incarceration, they're 10 times more likely to be to experience homelessness in their remainder of their life, right? So certainly it's not preparing people for living in an apartment, and in fact, maybe actively contributing harm in that way. Odds are we have people in our life who we know and love who experienced some of these same challenges that we've been talking about, these environmental factors, these individual factors. And in fact, we heard a stat somewhat recently that around 49% of folks in the United States are not able to afford a surprise $400 emergency expense. What that tells me is that many, many, many of us, nearly half of us, are about $400 away from housing stability, that difference between housing stability and being unsheltered, right? Oh, thanks for adding those additional thoughts, Felicia. When people have incarceration histories, they're sort of shunned in various communities, right? Yeah, and I think we see this in like the leasing process, the rental leasing process, where people do background checks on tenants and will not welcome people with a criminal background. Yeah, thanks for that clarity, Felicia. Appreciate that. So many things can contribute to homelessness, can cause homelessness. I want to kick it over to Christina to talk a little bit about kind of this chronic homelessness that we've been saying a little bit so far.
Yes, and I see Jill made a comment or take advantage of programs to help pay with rent. So we'll continue this discussion throughout the night on all of the barriers that this population faces when they are deemed this chronic homelessness. So we define someone as chronically homeless if they've been homeless for at least 1 year or have experienced homelessness multiple times within a specific time frame. I don't know if it is state specific. Ryan can correct me, but at Pathways, you have to show 12 months of chronic homelessness within a 3 year period. So if you can't make it within that one full year, we need to find a way to get a year of homelessness within 3 years. And thank you, Ryan. That is a federal definition that HUD sets. And those who are usually chronically homeless are the ones labeled not ready for housing, right? They're the ones that the short fix didn't work for. Of, hey, let us, wrap around you, but while you can jump right back on your feet. This is usually the population that did not work for it, probably because of a significant mental illness, substance use disorders, or other physical disabilities. And so they may have tried those programs and failed. They may have tried those programs multiple times and failed. And so what, as the system, do we do at this point? And that's where Housing First comes in, right? The sometimes deemed the hardest of the hardest participants are the referrals for Housing First programs. And so as we continue the conversation on, what's wrong with the healthcare system, we want to share a quote from Hillary Melton, who is the executive director of Pathways Vermont. Right, the mental health system as it isn't accessible to thousands of individuals. So what are we doing wrong? Imagine a hungry person with a wallet full of money is standing outside of a restaurant, but not going inside. The restaurant owner is changing his window display, offering specials, trying to get the smell of fresh bread outside. And yet the hungry person with his wallet full of cash still won't come inside. That is what's happening with our mental health system and the people who need it most, right? We know that there's a need. Everyone can kind of see the increasing need, but those of the highest needs, right, that Housing First population are usually not being engaged in a way that really meets them where they're at. And that is something, a theme that we'll carry throughout the night, this patient-centered or participant-centered care that we really specialize with at Pathways on, what can we do to meet you where you're at to get you to engage in treatment, not trying to force all of the treatments on you, right? Because we know that not everyone or anyone becomes homeless because of a moral deficiency, right? You're not good enough. You're not a good person. But as Ryan kind of hinted at, there's a lot of environmental and individual factors that kind of lead up to the systemic failures.
Can I chime in here? I'm wondering, one thing that I'm thinking about in your community that you're developing will be perhaps an urge to say, why are you not engaging this person in care? X problem is happening. What's going on? Why isn't this person in treatment, right? And I think this quote starts to pick at that a little bit. We'll talk more about that as we go, but something about that set of services may not be attractive to the person who's being served, right? And I think trying to find a way to make it attractive or to actually meet a very specific and self-identified need is really what we're talking about here with Housing First. These folks have tried other programs and not been successful. And other providers have looked at them and said, they're just not ready for housing. And we want to reject that concept and say that maybe we need to try a different way.
And it's similar principles that we can apply to kind of getting anybody motivated to do anything. If I tried to get everybody on this call to run a marathon next year, I would have to convince each and every one of you a different way to go about it, right? Or you're all going to be like, absolutely not, you can count me out. And so when you're faced with this overwhelming goal, you need to engage in treatment, you need to be abstinent, and you need to do all of these things in order to get your housing. Right, that's when a participant can kind of shut down and not want to engage in any of the treatment system. And so as we talk about all of those increased barriers, we see some of these indirect things that we don't think of sometimes. Why are you not going to see your doctor and taking all of your medications? Well, where can I store them? Do I have transportation to and from the pharmacy if I'm still unhoused? Can I afford the copay? If I have a follow-up appointment, can I remember the appointment? Right? Do I have a smartphone that is telling me on my calendar? Am I keeping a piece of paper that I have to keep safe? If I miss it, how do I reschedule? Do I have the phone number to the office? right? And so something as simple as having a cell phone is a really big barrier for those in the homeless community. And so that could be for rescheduling the appointment, for having the alarm to wake you up, um, to getting in contact with the doctor, maybe doing a telehealth, right? We've seen a big immersion of telehealth throughout the pandemic, but if I don't have access to any of those resources, I really am not able to utilize those. And then, where can I charge it? If you were to gift me a cell phone today, but I'm still not housed, where could I charge this phone? So these are some of those little barriers that um, really go into the housing first model, and we'll talk about later, kind of addressing the basic needs before we can overwhelm ourselves with a lot of the needs that as community members we think are the positive outcomes, such as engaging in treatment. And so as we look at those hierarchy of needs, we're going to look at Maslow's hierarchy of needs, which is a motivational theory that we use in psychology. So this one is a pretty social worky slide. We talk about this a lot in social work. And it's this idea that we need to meet our very basic needs, our physiological needs of food, water, warmth, and rest. So housing. Um, and those safety needs before we can ever get to our self-actualization, before we can reach our full potential and get back into the workforce and really get back to reclaiming our lives, which is a core value over at Pathways, which at its core is the housing first model, saying we need to provide that physiological safety for this participant through housing. And then we can address their relationships with community members and their relationship with their family, and we can address their self-esteem and their feelings of accomplishment, and that interview process before they're able to kind of re-immerse themselves in the community completely. I think a lot of us see the end goal, but it's the idea of walking before we run, right? We cannot get to the finish line if we don't address those basic needs through housing first.
I just want to take a moment also to contrast this with a more typical, like a more traditional approach, which is flipped on its head a bit, right? You might see in other types of housing programs an expectation that people complete a drug rehab program first, or make sure that they've been seeing a psychiatrist for some length of time, and then they'll sort of earn their way towards housing. So we're flipping that on its head and suggesting that if these are kind of the basic human needs, and these hierarchy of needs are not just for clients, they're for all of us, right? When we meet these needs, we tend to sort of naturally start to move up that hierarchy. People want to be in treatment or at least feel well, right? People want to take care of their mental health and their physical wellness. But have you ever tried to get sober from the street? That's a big ask, right? And so we're wanting to kind of make that process easier or follow a more natural progression.
And as Ryan has mentioned, this is the evidence base. This idea of 0 to 100 may work, few and far in between, where someone could jump throughout these hierarchy of needs or go right into the treatment system. But what we really want to emphasize is the focus on patient-centered care and it not working for everyone. One size does not fit all, and we're talking about a population who's usually the referral source for housing first.
So from our perspective, while much of the treatment sort of settings available, the housing settings that are available, while that can work for some people, as Christina asked, we're focusing on the folks who are sort of the most vulnerable, who have tried those other settings and not been successful, and as a result have been on the street long term. And that's the heartbreaker for us as housing providers, right? Seeing people who are having to live on the street long term when they want to be inside. We know they want to be inside. And so for us, the good news is that homelessness is solvable. And we think the way we do it is by focusing on these 5 key principles in sort of like housing operations. So these are the 5 key principles. We're going to take a kind of a closer look at each one of them. I will say, housing first, I keep harping on this idea that it's evidence-based, and that's really important to us, right? We want to do things that work, that use science, that have said like, these are the outcomes you can expect. And people talk about doing housing first, but you're only going to see those good results if it's employed to its full extent, right? And so sometimes we'll talk to programs that say they do housing first, but then they're not doing these key principles. And I would say that's not housing first, right? And so let's talk about what each of these are. The first one is immediate access to permanent housing with no housing readiness requirements. I think this one can be tough for some folks out in the community to wrap their heads around this idea that like people don't have to prove that they're ready for housing. Well, why? That's based on this idea. Everybody deserves a safe and permanent place to live. I think I deserve that. I think you deserve that. Everyone means everyone. No matter what they look like, no matter what their zip code is, no matter what politics they espouse, whether they're white or black or native, or they're an immigrant, no matter what good or bad choices they've made in life, I believe, and a Housing First program tends to believe, that everybody deserves a safe and quality and affordable place to live. I'll say too, we believe that housing is a human right, not a privilege, not something we expect people to earn. And so this is where Housing First type services really flip the traditional models on their head, right? Where previously people were expected to earn housing, we're saying, no, housing is a human right. Now, what are we going to do to help you improve your life now that you're housed? Safety and shelter are primary. The corollary to that is treatment and recovery are secondary. And this idea of housing readiness. Let me ask you this question. Do you ever ask a hungry person whether they're food ready? Not usually, right? If you believe that housing is a basic and universal human right, then I think this idea of this person is not ready for housing is kind of bogus, right? So I see some questions coming in the chat. Great, I love it. Let's dig in. Rachel mentions, are there housing first programs for families or couples? I do believe that there are. There's one we can think of in New Jersey. I can think of in New Jersey. I'd love to hear your perspective on this too, Christina. But as the model was written, it's for single adults. Now, I think a lot of our participants do have partners or other people that they bring into the house. They're sort of doing that sneakily, or sometimes we turn a blind eye to it when it's not causing any housing problems. But it's when you're using a harm reduction approach, and I'd love to hear from you about this too, Christina. It's kind of sticky ethical waters, right? Maybe there are kids in the home, but there's also drug use in the home. What does that look like? Anything to add there, Christina?
Yes. So, Rachel, for couples, we don't lean into it for housing first, but it's not unheard of. Even at Pathways, there are a couples that are housed together, but it is few and far in between. Like Brian mentioned, it's really just not what the model had initially geared towards. And there's usually a lot of interpersonal violence and a lot of other dynamics that go into couples who have been chronically homeless together that kind of impede all of those hierarchy of needs when housed together. In terms of families, that is the one that I would be hard pressed to refer you to a housing first, the true housing first program, capital H, capital F, because of the active substance use. If it was just the significant and persistent mental illness, that's a different conversation. But as we're seeing, a rise of substance use co-occurring with mental health, anytime there's substance use involved, most states are mandated reporters, which means no active use can occur when there's children in the home. So if we were to have a housing first family program at Pathways, we would not really be able to uphold all of the values of capital H, capital F in terms of punitive measures because of state mandated reporting.
Thanks for sharing that.
And then I see, a couple other questions coming in from Ben. Does no housing readiness requirement contemplate providing identity documents, which itself can be a challenge for folks? And would a housing provider who does not have the requirement of minimum proof of identity be considered housing first? And Ryan, maybe you can chime in on other programs and what they require. At Pathways, it is not uncommon for us to receive a referral. And so Ryan had mentioned earlier, we receive our referrals through the Department of Behavioral Health and the City of Philadelphia without any of those kind of documents. We can get a description such as Ben Snyder on the corner of Front and Washington in a gray sweatshirt, and kind of we work from there, gathering all of the basic information such as the social security number, and then verifying identity from that point. And then Ryan, if you can speak to if a program did not require that low barrier function, would it be considered housing first?
I think it could be, Ben, if it also met some of these other qualifications. So I think, yes, I can. I'm not aware of any specific ones to kind of like offer a specific example, but yes, lowering the barriers to entry by not requiring these identity documents is kind of part and parcel of what we're talking about here on this key principle. And in fact, sometimes what we see are these like quote unquote readiness requirements that they're not written into policy, but if a program requires somebody to run around the city and collect all their documents and go to the Social Security office and get their birth certificate, that ends up being a de facto readiness requirement. Many of our folks would not be able to manage getting all those things together on their own. And if the only people you house are the people that can manage to get all those documents, then you're kind of selecting out all the folks that need our help the most, right? So that's a good question, though. I'll echo John's comment here that says another factor to this list, and as with Easter's Home, housing literally saves lives in some, if not many cases. Yes, mortality rates of the unhoused are high when unaddressed. Absolutely. And we'll take a look in a little bit around health. Health just improves across the board when people have a roof over their heads, regardless of whether they engage in like other supports. Yeah, I think Lori is kind of touching on something that I think is really important to say. We make this distinction between high fidelity housing first and a housing first approach. And so the more components of a housing first program that a program implements, the better we think it's going to be in terms of those outcomes. But Lori correctly notes that there are family providers in our community who value housing first principles, but the intervention may not be at the same level of that fidelity criteria. And there's a bunch of evidence that families do better when we lower the barrier to entry. And so Lori provides a pretty cool link to a study to look further at that. Thanks for sharing that, Lori.
And Lori also hints at the idea that we've been mentioning that not one size fits all. So even at Pathways, we have very few blanket statements and requirements, but one of them being, we are a mandated reporter, as I mentioned. So if you were actively using, you could not have a child living with you. But as Ryan mentioned, people do things a little bit on the sly, and that's okay. And so when we have a more stable participant, meaning stable in their recovery, and they want to reconnect with their family and have their family over, they're allowed to do that, right? There's not this blanket statement that you are a Pathways participant, you could never have these visitors. And it is a very case-by-case situation. And so it's great that you guys have some family providers that are practicing with those core values.
Yeah, I love that. Okay, here's our next key principle: participant choice and self-determination. This is language that we use in the social work field a lot. And so I'll try and, I'll try and just kind of describe what we mean by this here. We try and provide services that are person-centered, as opposed to services that are program-centered, right? We could do our program in such a way that like we rolled it out for everybody the same way. First you do this, first you enter this treatment, first you get your home, then you enter this treatment, and then after 6 months, you'll see the therapist. We could roll it out in a very sort of procedural and specific way, but that wouldn't meet people where they are in their journey. And so that's always going to be our goal, is to be centered on the person in front of us and what unique challenges and strengths that they have. We're really focused on dignity here. And part of that dignity is offering choice at every step of the way. So for example, in our program, I mentioned we do scattered site housing first. It'll be a little different than your community, where everybody sort of lives in one place. Our folks live all throughout the city. And for them, they get a choice of what neighborhood they want to live in. That might even be one of the first few questions we ask them. Hey, what section of the city you want to live in? Do you want to live closer to your family, or do you want to get all the way away from them, right? And that could be a key part of their recovery journey, is making that choice. Do you want to access a therapist or not? You get choice there. Here are some benefits. Here are some challenges with it. It's up to you, right? Do you want to take your medications or not? If you don't, there may be these consequences, and we'll support you through those consequences, but ultimately it's going to be your choice, right? Kind of our goal is going to be to promote empowerment at every step of the way. And part of the reason for that is people are going to feel so much better about their lives and about themselves if they can make the choices to get them to where they want to go. They guide the course of their own treatment. This can be challenging, I think, at the provider level, right? I think some of us have been trained to sort of be the experts of care, or like, this way of living your life worked for me. It should work for you. Please do it this way. And I think we have to sort of like take our hands off the wheel a little bit. These are human adults that we're talking about. Yes, they have some disabilities and some challenges that have led them to the experience of homelessness, but they're still people. And so that choice and self-determination as a key factor at every stage of the process is really important to us. Let me kick it over to Christina to talk about this multiple pathways of recovery concept.
Yes, and so another kind of guiding principle that we have here is going to continue those themes of participant-centered care and redefining recovery, right? So echoing that this does not force treatment, that we are helping support our participants define what their recovery looks like to them. And then this is where I go back to all those analogies of not running before we walk, of what is our short-term goal going to look like before we get to the long-term goal, right? And that's when we get back to evidence-based stuff. And a lot of this relates to human behavior, not really just social work of, are you more likely to complete your goals if I try and get you all the way to your long-term goal first? Let's get some short-term goals that are really realistic to be achieved in this time frame. And developing those goals can be scary. And that's where we see a lot of our peer integration and our peer support. We have certified peer specialists and certified recovery specialists, community healthcare workers. These are all employees who have lived experience in mental health, in substance use, that relate that lived experience to what that participant is kind of going through right now and what they might be willing to engage in. And all of this kind of promoting the harm reduction strategy and approach that we believe in, and recognizing a holistic well-being. So the role of social, recreational, educational, and employment activities, all as recovery options. Some people kind of lean into, work or one thing when they're in recovery, and knowing that it may not be that for somebody else. Another key principle that we want to talk about here is individualized and participant-driven supports. So really echoing that one size does not fit all. There is no standardization. That ignores individual experience when we give this cookie cutter approach where all of our services mimic each other and they're not really individualized to anybody. And so these services need to be tailored to each individual. That's how we meet people where they are. And that is really social worky term, meeting people where they are, that helps the participant really be engaged in their care plan, dictating which supports and services they're actually interested in engaging in, versus kind of the traditional mindset of us dictating what treatment services they have to engage in. And all of this kind of relates to on-demand support. So when that day comes where they say, okay, I'm ready to engage in treatment, or I'm ready for the next step, that there are supports and wraparound services for them. And it all goes back to their choice in all areas of programming when it relates to their housing. So like Ryan mentioned, we are able to kind of offer a lot of insight into where they want to live, that autonomy, but also in their healthcare, their mental health, and their substance use, really letting them be a part of their treatment plan. And then the last key principle, go ahead.
I wanted to give one quick example of this, like, no one size fits all piece and like the no standardization piece. Our outreach manager sometimes talks about the way that, like, sometimes she'll go out and meet people under a bridge who we've never met before, and it's time to ask them if they're ready to come inside, and they're like, no. First, I want to do this, this, and this. And we're like, why? We have an apartment ready for you. Come inside. What are we doing? Meeting somebody where they're at, and Lori notes that maybe that's also used in a theological context. I'm glad to hear that. So maybe it's not an unfamiliar concept. Meeting people where they're at means like we want to follow where a person is wanting to go, and the program is not going to look the same for one person as it does for another person, right? And so if somebody says, no, I want to do all these other things first, and then I'm ready to come move inside, we're happy to do that, right? We're happy to sort of help build that relationship with them by following their lead and creating the service set that is going to work for them. And then when they're ready to come inside, they will. Sorry, Christine, I just wanted to add that a little bit.
Yeah, thank you, Ryan. And so our last key principle here is social and community inclusion. And so at Pathways, we're very big on community inclusion. We are fortunate enough that we have a community inclusion department. And so those certified peer specialists that I was mentioning, they are very integrated in our community inclusion department. And we are able to kind of reintegrate into the community. What does it mean by reintegrating? We do a lot of meaningful social activities, such as Restaurant Club. Restaurant Club is a huge hit at Pathways. Once a month, our community inclusion department organizes a new cultural restaurant. So one month it could be Italian, the next month it could be Thai. And they take a group of participants and staff to a restaurant and they have a formal sit down meal, which is huge because for a lot of our participants, they may have had never done that. They may have not done that for 10 years and don't know what it's like to review a menu and place their order and pay for the meal at the end of that. So that's a really big community inclusion event at Pathways. But we also have things like Movie Club, where they can hang out and watch a movie or go see a new movie, Garden Club, and a lot of other patient-centered activities, right? So if you're just feeling down a little bit, you're like, hey, I really wish I could have a girls' day. I've not gotten a mani-pedi in 10 years. It's been a really rough time. Let's work on getting that. Let's get a staff member together. Let's take you guys out to lunch and let's do that while we work on your goals. And what we're saying is that community integration helps participants reach their goals. They're more likely to then come in and engage in the next step of their care plan. That relates back to that hierarchy of needs, right? Once we're addressing that physiological safety and that security with their housing, we're continuing to show up and meeting them where they're at and supporting them with all their needs, the more likely all of our participants are to engage in the next level of their care. And I'm going to kick it back over to Ryan.
Yeah, I was going to add that I think another kind of message that people experiencing poverty have received over and over again is that they're not allowed to have fun. If you're poor, if you're homeless, you're not allowed to do things that could be perceived as like care for yourself or buy things, or just like live the way most of the rest of us are living. And so sometimes this community inclusion piece helps people tap back into like what it means. A mani-pedi, if you're homeless, can you imagine the kind of stink eye that somebody would get if they were actively homeless and tried to go in for a pedicure? I just, it's not like that stigma of being homeless follows them everywhere, right? And so kind of re-tapping into all the great stuff that all of us take advantage of to make our lives better is part of what this key principle is about. And I do think providers. Oh, go ahead.
Yeah, go ahead, Ryan. I was just going to say perception can match reality, right? When we continuously stigmatize this population and say, well, no, you kind of don't deserve a mani-pedi because you're homeless, or you don't deserve a mani-pedi because you're homeless and we don't want to sit next to you, the less likely they are to ever go get the mani-pedi, right? To ever engage in the workforce and then use their money to go get the mani-pedi. They're kind of turned off to this idea of engaging in that because they feel so dehumanized in that act. Go ahead, Ryan.
Yeah, I agree with all of that. And I'll also say it's not just out in the community where they receive that stigma. I think also providers ourselves can be guilty of saying, no, don't do that thing, or not focus enough on these like meaningful social activities and focus so much on goal planning work. What's the treatment plan? How do we adhere to it? How do we get you on track? And sometimes lose sight of the stuff that makes life worth living. And so I think as Christina really was doing a good job of highlighting, when you can do all this meaningful social stuff, all the treatment-oriented goals are so much more manageable. So it's a big part of the program. I think it's a good time for a break. So before I send you away for a break, we're going to get into the benefits and challenges of a Housing First type program. Let's open the floor again. Are there questions, comments, kind of things that people are chewing on right now as we've gone through this content so far? Raise your hand if you're asleep is my question, I think. Or whatever other questions you have. Nancy, I see your Zoom hand. Hit us.
We might not know the answer to this yet, and maybe it's a question mostly for John, but I wonder then what the social inclusion part, what we think that might look like in our program, and kind of, I guess, like what our part is in that versus Roof Above's part.
A very brief answer, but I think all the experts would say our part first is to listen, and listen long and listen deeply, and let our neighbors get settled in. As I've written before, we've got 300 members who are all going to want to run over there on day one with the casserole, and that may or may not be quite right instinct, but if you think about what we did with the shelter, over time, we listened to the residents, and we ended up having five different programs throughout the week each night based on their stated interests. So that's a general answer rather than a specific, but I think the experts would say, make no presumption, listen first, listen deep. And then knowing Caldwell, I know y'all are ready to love, the minute that we feel like it's the right time.
Yeah, thank you.
Something to that as well. Lisa Thompson is not able to be here tonight, but one of the bodies of work that we need help with right now for Easter's Home are a person or two to work with us on that model. What is the part, because Roof Above has tenant engagement specialists. They are also very excited about the Caldwell capacity to provide additional things. And we need to sit down and map that all out over the next couple of months. So if somebody has a particular pull on their heart for that question and helping us figure that out, please see me or see Lisa, and we'll talk about it. Thanks for letting me have a commercial in there.
Yeah, thank you. I really want to echo what John said though about listening to your new neighbors, and then kind of letting it guide from there. Really, the participant feedback is going to be the most crucial piece, because it sounds like you guys are all ready to run over there with the casseroles, which is phenomenal, but that can be very overwhelming. And so that slow burn and build up will be really great. So it's great to hear that you guys already have that belief in place.
Well, thank you for mentioning that. And one other aspect that, because I know it's kind of frustrating to have to wait, because I know y'all's hearts, we will be and have been and will continue to tap into those folks with lived experience. And so while we want to listen to the 21 people who move in on Fifth Street and their individual life goals and needs and desires, we can categorically, per Ellie's point, talk to people with lived experience, and they might give us some general guidance. You might think about this kind of thing or that kind of thing, or stay away from this kind of thing or that kind of thing. So we won't be completely sitting on our hands. And the good news is our congregation is full of people who are in this work already. So between the lived experience, tapping into Roof Above's given experience, they manage 700 scattered site apartments around the city already. And people like Nancy Pugh and Rachel Eldridge and Laurie Thomas and others. We won't just be twiddling our thumbs for the next 9 months. We'll be thinking about framing out some stuff, but then we got to listen.
I love all of what I'm hearing from all of you. It sounds incredible. I'll just add one other piece of feedback that I think whatever you settle on, and it will probably continue to evolve over the years, right? Whatever sort of level of programming or community engagement that you do, I think it will be hugely beneficial if that can be sort of a quote unquote normal experience. In other words, I don't think it can be programming that you're sort of like doing to people, right? I think you should be engaged in programming that you're doing with them. And if sometimes they don't show up, or maybe only one person shows up to like the knitting club or whatever you do, great. That's fine too. Sometimes it's only one church member and 15 people at the knitting club. That's fine too. But I think sort of this idea that there's community happening and they get to be a part of it at the level of choice that feels right for them. But that you're not sort of, I think to Christina's point about the overwhelming, I think it could be very easy to sort of like, come to our movie night, right? And they're like, oh, that's a lot. Maybe in 2 years, right? And so I think the kind of normalization of social activity with your neighbors. It's the same thing I do with my neighbors, right, at home. And I think kind of taking that neighborly approach is going to really go a long way in terms of sort of just like settling down the intensity of the interactions.
And one last thing, not to drag this out, because I know we need to go take a bio break, is that one of the things to keep in mind, you all, is ministry of space. So what is the role of the third place, which Ryan, unless it's a 1,000 square foot space we have that we've used as a coffee shop before. So what is the role of that, just as space to be outside their 400 square foot studio efficiency apartment? So those are all questions in front of us. No decisions have been made. They need to be y'all's decisions about how do we want to use our spaces and which ones do we want to invite our neighbors into on a regular basis. Those are all questions out in front of us.
Great. So I have 4 minutes past the hour. Let's take 5 minutes. Let's take 6 minutes. We'll feel good about that extra minute. Let's come back at 7:10 and we'll finish up the second half. Alrighty. So this next section, we're going to focus a little bit on the benefits and challenges of a housing first approach. It is not all tea and roses. There are some challenges, but we think the benefits are really worth it. I'm glad to know that you're partnering with such a skillful organization in A Roof Above, by the way. I think you're going to see these benefits, and I think they're very well equipped to manage the challenges. So from my perspective, some of the benefits of Housing First include the fact that there is this 30-year track record of evidence. That's really important because, as we'll see a little later, homeless services in general don't always, sometimes what we see is kind of we do it this way because we always have. And so it's really nice, I think, for us as providers to be able to kind of tag back into this 30-year-long track record. One of the main outcomes that we preach a lot, you've probably even heard me say this, is this 85 to 90% retention rate after 5 years. It's quite common for people to receive support when they're experiencing homelessness, but then to experience further bouts of homelessness in the subsequent years of their lives. What you'll find in a high fidelity Housing First program in particular is after a 5-year period, 85 to 90% of folks housed remain housed. And I think that speaks to a lot. It speaks to our assertiveness in like trying and trying again. And so frequently what you'll see in a Housing First program is if somebody loses that first apartment, we might help them into a second apartment, maybe a third apartment. We have folks who have been housed in, I don't know, what, 5, 6, 7 different units sometimes. Sometimes it's through their own choice making. Sometimes it's things that are outside of their control. But the opportunity and ability to kind of continue working with people and continue giving opportunities for new and more skillful decision making is a critical part of the Housing First model. It is hard to live independently if you haven't done it for a long time. And so we recognize that like that's going to come with some bumps. And I think this retention rate speaks to the flexibility and patience to like roll with some of those bumps. I think what you'll also find as a benefit is a decrease for more expensive programs. Thinking about programs like long-term shelters or transitional housing programs. These are expensive programs that we can reduce the need of the more permanent housing slots become available, right? And so as you have people housed permanently, you don't need some of this like shorter term stuff. You still do need some of it. We're talking about kind of the difference between chronic homelessness and maybe more short term, brief homelessness, right? What you're also going to see is increased medication compliance and treatment adherence. I say this like very specifically because at no point in a Housing First program do we require people to be med compliant or treatment adherent. We don't require it up front as part of their eligibility, and we don't require it down the road. And yet, despite not requiring it, despite lacking that coercive element to a Housing First program, people do comply with their medication regimens and they do comply with their treatment. It's because they're making the choice to do it. And so that's a kind of a fascinating component we see here. It's also going to decrease hospitalization time, especially like behavioral health hospitalization time. So people are frequently hospitalized with mental health challenges when they're in crisis. Our folks also become hospitalized, whether voluntarily or involuntarily. And it's going to decrease the need for that. Often because they have a place to go to, right? Like the hospital staff have somewhere that like they know they're going to, rather than discharging somebody to the street who they know is going to be street homeless. They're discharging them to their own apartment and a care team that's wrapped around them. We also see an increase in participant satisfaction in Housing First type programs. That's usually attributed to those efforts around community inclusion. And so once again, kind of thinking about Easter's House and the opportunity to like provide this crucial community benefit piece is going to contribute to increased satisfaction with the services and with the housing option that they have available. We'll also see that satisfaction attributed to family reunification, increased independence. These things are not always offered by traditional housing programs. Yeah, I see Rachel adding a comment, and we're going to make some specific comparisons to shelter a little bit later, Rachel. But Rachel says, shelters are often rather structured. Eat at these times, be here by this time to get a bed, etc. Do some folks struggle with setting their own schedules? Oh, that's not the question that I thought you were going to ask, or the comment that I thought you were going to make. You're 100% right. And yes, they do. I think that we can think of living independently as a skill set. Now, is it a skill set that you have to consciously think of yourself at your age, in your circumstance? No. But I had to learn this at some point, and you had to learn this at some point. Maybe it was at a younger age or with more support around you. There is a skill to living independently and setting a schedule. And so we will support people in making those schedules, but we're never going to define them for them. Right. And so there's no such thing as a curfew in a Housing First program in the way that I understand it. Right. There's no such thing as you can only have certain guests over between these hours and these hours, or you can only come in and out of your house at these times. Do you want to add something, Christina?
Yes, and Elena, I do see your hand raised there. There's this idea sometimes that because we believe in those core principles of Housing First, that there is no curfew, that it's being encouraged. And that's also not true. That is a misperception. Kind of our role as the care managers and those wraparound services is to encourage the best behavior, right? Those positive outcomes that community members such as yourself are looking for, of saying like, hey, it might not be a good idea to be out all night. Like you have work tomorrow morning. Maybe you should set a curfew for yourself at 10 p.m. And so those are the conversations that happen with the care managers and on that individual basis. And what's working for you? What have you tried? And hey, maybe your way's not the right way. It hasn't really worked out. And kind of these motivational interviewing that we call it in social work, those kind of encouragement and coaching skills are kind of the background conversations happening with the participants and why we're able to kind of report on these other outcomes, such as engagement in treatment and medication adherence and decreased hospitalizations, because there is someone encouraging those positive outcomes. We're just not mandating it.
That's a great reframe. And I'll say, I think the idea that schedules are often defined by like human rhythms, right? Like I think as humans, we like routine. And I think that's true for our participants as well. Their routines have been a little different if they've been living on the street, but I think the encouragement and the retapping into a routine that feels good for your body now that you're housed, now that you're eating 3 squares a day, I think we see people sort of naturally move into those rhythms, as well as Christina mentions, the kind of encouragement around, you seem like you feel really bad every morning, but you're staying up till 3 a.m. What's going on there? What do we do there? Okay, Elena, we have pushed off your comment for too long. Your hand is raised. Please ask your question or make your comment.
That's okay. Can you hear me?
Yes, we can.
Okay. Mine is a comment more than a question. As most people on this call probably know, I do already work with Roof Above at a supportive housing community for seniors 50 and above. And one of the comments or questions that I think Rachel had was about, shelter life is pretty structured, whereas when they get into, independent housing, whatever. And I do find that the people that I work with have found it really difficult to transition into being responsible for their own bills, for when they pay their rent, for how they pay their rent. And, for them, it's really a learning process because a lot of things have been provided for them. And that's a good thing, but they get into a rhythm of that, of providing, and may not really even understand, how important it is to pay your bills on time, or if you can't do that, to get somebody who can do it, because we also do have people who have, I forget what they're called, but they're organizations that receive the money that our seniors receive and then pay their bills for them. And sometimes they're not happy with that, but at the beginning, it might take some time. So anyway, I just wanted to comment that getting back into a normal life, quote unquote, normal life for them, there's a lot of little things like that, like paying your bills, like cooking for yourself. You even said you're getting 3 squares a day. Well, I don't think a lot of ours people do get 3 squares a day because they don't, they're responsible for making the food, as opposed to when they were in a hotel. I was the one that gave out 3 squares a day. I was the one sitting at the front desk, and if they wanted to eat, they got breakfast, lunch, and dinner. So there's just a lot of things about living the kind of life in independent supportive housing that they just may not be used to or need to relearn. So we have to be sensitive to that.
Yeah, Elena, I really love to hear that, because at Pathways, I mentioned earlier, one of the core values is reclaiming lives. And I have seen even at Pathways, it's not necessarily a reclaiming of a life if I never known that to begin with. Kind of a lot of those independent life skills. We have some unique participants at Pathways that have gotten younger and younger on the substance use side. We are seeing a kind of an elderly homeless population in general, but when we're talking about specifically those with a primary opiate use, we saw it trend a lot younger, and this generation who don't have the life skills on how do I cook myself 3 meals a day on a fixed income. How do I wash my clothes correctly? Kind of a lot of those little life skills that we've had to think, do staff train them? What if some staff don't know how to do some of that for themselves? So that's where that community integration piece comes in. And you guys as community members can maybe lend a hand on kind of what we think of as these basic life skills can seem very overwhelming to someone who does not know how to do them.
Yeah, I love it. I'll also say, from our perspective, a Housing First program tends to have a quicker startup time. We're kind of speaking apples to oranges, I think, in this group. Your startup time is lengthy, and it needs to be. You're sort of preparing very carefully for a group that's going to live on your premises, as opposed to maybe a more, I guess what I would call a more traditional high fidelity Housing First that's scattered site. We're just taking a subsidy and going and renting an apartment. And so from that perspective, it can be kind of quick startup. So I think you have a lot more to think about, a lot more to put in place. And I think that's right on. Like, I think that needs to be the way it is. We do think that there is a wider community benefit to a Housing First type program. you're literally helping 21 people not be homeless, right? From my perspective. And so in addition to the improved quality of life benefits that those folks, those individuals are gonna have, there's gonna be quality of life improvements for the kind of broader community. Are there less folks sleeping on the street? Are there less people walking around with unmanaged mental health symptoms or substance use or kind of affecting a neighborhood community in some way? I think you may have heard us talk about last session, we talked a little bit about how our business district kind of does this, you scratch our back, we scratch yours. They don't want panhandlers in front of their businesses. We don't want people to be homeless. We want people inside. And so they actually fund some of our outreach work to go and meet people and help encourage them to come inside. And so the kind of you scratch my back, I'll scratch yours piece of this, these are your neighbors, literally and figuratively, right? And so I think you're going to see everybody's boats rise as these 21 folks get housed in a small way.
And
Go ahead.
and not to put any pressure on these 21 neighbors that are going to be joining you, but don't shortchange them. I have been so surprised and impressed with participants that I've encountered at Pathways who've had this amazing life skill that has kind of been suppressed over the time of their homelessness and when their mental health was so prevalent. Whether it be a DJ who would tour the world, and when you would Google him, you would see old concerts that he would play or tech skills. And so there's a lot of those hidden skills that are going to benefit the wider community too, if you guys support and embrace these neighbors.
All right. I think John started to kind of touch on this a little bit around mortality rates earlier, but wanted to just share a slide. We stole this slide from a group called Corporation for Supportive Housing, CSH, who they're a partner of ours in supportive housing work. They're a national company. Anyway, when people are housed, there are great benefits to their health, right? Number one, it's going to prevent onset of some of those new illnesses and injuries that people are going to collect as they're living unsheltered, right? What does it mean to live outside in the hot and in the cold? These things are going to contribute to illness and injury. If you're sleeping in a tent and you have some belongings, are there people that are going to rob you and hurt you? People are assaulted frequently on the street, right? And so simply being inside in your own unit is going to prevent this whole category and a whole range of illness and injury that are going to pop up. Of course, when you're connected to a program like a Housing First program, it improves your access to high quality and coordinated healthcare and other critical social services. Here at Pathways, we have a clinic right here on site that most of our participants receive their primary care through. I know that Roof Above has connections to kind of the broad range of medical, socio-behavioral health providers, right? And so it's going to be much easier for them now that this person is in a program to connect them to those needed supports. And you're going to manage kind of ongoing health challenges in an effective way, a more effective way. And of course, being in a home promotes lifestyle behaviors that lead to good health. Sleeping in a bed is better than sleeping on the ground. Having access to a kitchen to cook in is going to lead to hopefully better health, as long as there's that support, right? Like that skill support of how do you cook? How do you grocery shop? And of course, that's our work, right? Some folks kind of join Pathways and they're like, I didn't become a case manager or a social worker to help somebody like clean their apartment. Like, that's not what I do. And we're like, you work at Pathways. Yes, it is. That is literally what you do. It's that skill work alongside people who need that development, right? And that support. And so all of those things are going to lead to better health, and those are going to have lasting health effects. One of the key indicators that we see, I may have rattled on some of this last time, but when people are experiencing homelessness, their key way of getting care for many folks is going into an emergency room. And so we see folks with like 40, 60 visits to an emergency department in a 6-month period. That drops dramatically when people are housed, both through the conversations that we're having with them, the connections to other care options that we're providing them. And sometimes people are simply going there just to get warm and to get a little snack in the emergency department, right? And so all of that goes away, and we see such better kind of health stuff. Looks like John is mentioning, Lori says that CSH does work there in North Carolina, some shared work. And then Novant Healthcare pays for and has embedded 2 nurses who work only for Roof Above clients. Cool. I love that. That's somewhat similar to how we do it here. We have nurses on each one of our clinical teams, in addition to the primary care clinic that's on site. And so again, reminding you or restating that a Housing First is a holistic intervention. It's not just about the house. It's not just about the mental health care. It's like whole person. And I think, I don't know, to me, that's very exciting.
And so we kind of hinted at a couple of these ideas, but what Housing First is not. So it is not a new and radical idea. It has a 30-year track record and a lot of those evidence-based approaches. So this is not some backdoor, let's try it out for the first time approach. It's not housing only. And so all of those wraparound services that we identified earlier are needed to support the individual successfully. And honestly, without those services, it's likely not going to be successful, and it's really not Housing First, capital H, capital F. And then most importantly, and what may be on a lot of people's mind, is that it's not anything goes, right? This idea of Housing First means no accountability, that you're just allowed to do whatever it is that you want. And that's not true. It's the idea that choice does not mean ultimate choice, and that you won't face consequences for your actions. But there's also the idea that there's a threat of safety from these individuals more so than the general population. And that is also not true. You actually find that there's a higher rate of violence on those who have mental illness versus being the perpetrator, right? And it's up to us as providers to kind of counter that misinformation with facts and promote, the inherent dignity and worth of your neighbors. When you kind of count someone out, right, that perception that becomes reality, that messaging, if they feel that you've already criminalized them, they may be more likely to act in behaviors that kind of replicate what you already expect of them. And then this idea that Housing First is enabling, right? We're not enabling anybody when we're providing basic needs. As Ryan mentioned earlier, that housing is a basic human right. Kind of the talk of enabling is a way of saying, I believe that these people haven't suffered enough, or they haven't done enough to earn this housing. And so a lot of those criticisms are coming from the comforts of your own home, where you're able to live comfortably and raise your families. And so then I would challenge the idea of, like, is it a bad thing then if we were enabling, in this case, by giving someone shelter, giving them a place to live? And as we've been echoing, kind of an intervention that only works for some, and that this one size fits all approach. Common kind of criticisms of Housing First argue that it's a one size fits all approach, but we know that that's not actually the Housing First model and would not work in a true Housing First program. It will never work if you try and dictate the same things for all of the participants, that you would get all 21 of your community members, right, that are practicing Housing First. What makes Housing First so successful and kind of challenging are all of those individualized needs. Right, one of those community members, those 21, may be someone who has those 40 ER visits, maybe a little bit more complex, while another community member may not have those same needs. There's going to be a range across all community members, and if the program expanded, and so meeting people where they're at, it's all about individualizing their care plans. And so challenges, right? We've kind of talked about Housing First a lot, but acknowledging that it is hard. Some things kind of pop up, and you have to pivot when you can and really make decisions individually. And so we're screening people in, not screening people out. We're seeing a lot of folks that may have more chronic and complicated conditions and fewer resources and support, which can be challenging, especially when we're talking about the idea of independent living. So the idea of, if you're aging a bit and you're not able to live independently, what are some other resources that we need to provide in order to maintain a Housing First model? The system is also not oriented to serving those with the highest needs. So we're working within a system that maybe we don't have the funding sources and the allocation of the resources. That's always a challenge. Collaborating with non-harm reduction providers. And so everyone on this call is here because they want to learn more about kind of the Housing First model and how to support your community members, but you may have some who don't have buy-in. That's always going to be a challenge when you have someone who does not believe in the mission. Consumer choice can be a bit predictable. What does that mean? Because the model is based on consumer choice and individualized treatment, sometimes it's hard to anticipate how the program will unfold for each individual. It's okay to say that it does not work. I think that's also a scary thing in social work of like, well, wait, if this doesn't work and this doesn't work, this has to work. And we kind of spin the wheel trying to make it fit. And so sometimes we have to take a step back and think about that care plan. Are we kind of forcing the next step and what we believe that they should be working on, or are we really taking kind of their feedback into consideration here? And that's when we get into differing treatment needs. Some individuals require a congregate setting for a lot of reasons, whether it be, health conditions or the inability to live independently, the inability to be financially independent. They might be independent in other ways, but cannot maintain their bills on their own. Kind of those little pieces that can be tailored to each individual. And, it says here it only sounds easy. I don't even think it sounds easy. I think it sounds hard because it is hard. And, we're all trying our best doing this work. And that's where the participant feedback that you guys are already really motivated to get will come into play. Any questions here?
Yeah, this is a good one. Let's pause for questions. And I want to say, as you're kind of thinking of a question, or if you're chewing on some of this, I am imagining there will be circumstances that arise that you as a community say, oh my goodness, something has to be done about this. This is scary, or it's disruptive, or we're concerned, we're scared for this person. Like we're concerned, legitimately concerned about this person and like what's happening. And I think in the ideal world, and I'm sure that this will be the case, a roof above staff will be chewing on these things and they'll be beating their head trying to figure out what's the right thing. Pathways has been doing this a long time. We're really good at this work. We've been pretty successful, and challenging circumstances arise where the team gets together and they say, oh my goodness, what are we going to do about this challenge? We've never seen this before. And we're trying to kind of navigate, how do we maintain these 5 key principles? How do we maintain choice and self-determination? But also this is really disruptive and we don't want this person to have harm come to them or harm come to anyone else, right? So there will be hard circumstances. And I don't really have more to say beyond I'm expecting Roof Above to be like wrestling with some stuff. And I think giving them the space to do that is a pretty critical thing too, right? Being in open communication about the challenges, but then also kind of letting it kind of happen the way it's supposed to happen.
Yeah, and I would just echo with Ryan saying that, at Pathways, we are just in the fortunate situation that we're able to have those fights in-house. We're providing kind of all of the services, the community integration, the housing, the case management. And then when those cases happen, we all sit together, clinical, housing, all of these different departments, and go, what are we going to do? This is not okay. What are the repercussions going to be outlined to the participant? And then, that autonomy still comes into play of, you can choose to do this and then you can maintain your housing in X, Y, and Z, or you have the choice to do this. So they're still given that choice, but there is a consequence to their actions. And so at Pathways, the only difference is that we're having that discussion in-house across multiple departments. And with you guys, it would be more of a community coming together, raising those concerns to another agency.
I would suggest, you probably are already thinking about this, but I might suggest having some regular check-in point that the community's concerns can be voiced to Roof Above, right? And so that it doesn't feel like such a crisis moment. Who do we talk to? Who's the case manager? Where if there's kind of an ongoing and routine level of communication, where you can sort of raise certain concerns, they might then be able to kind of on a routine basis come back and say, hey, we're trying a couple of things with this person. Let's check back in a week or whatever, right? So kind of having, that's how we do it, right? We want to have a lot of routine communications about our participants, and then also opportunities for more crisis-oriented communications. And so I think maybe thinking through those structures if you haven't already. I see a question from Robert. Are there limits on who residents can bring in from the outside as guests or visitors? Are there limits on time of day? I want to be a little bit flippant with you, but I hope this can be a teaching moment. Robert, do you have those limits? I don't have limits like that. My partner might get a little mad depending on who I bring and when. But they're like social limits as opposed to like my partner's not gonna probably kick me out. Well, maybe they would. I don't know. Anyways.
But I'm not living in a home with a lot of other people unrelated to me also.
Yeah, my understanding is that these are efficiencies, yes? These are like individual units. And so I think one way that I conceptualize it, I haven't seen it, but one way I conceptualize it is like an apartment building. And so apartment buildings also don't have limits on well, maybe some do. I think there may be some apartment buildings that have those limits. My answer for Housing First from a pathways context is no, there are not limits like that. The limits that might exist would be when a participant has a bunch of people over a lot and the neighbors start to complain. But that's not uncommon even for like non-program type residents, right? In an apartment building, if you have a lot of parties, your neighbors are going to complain and the landlord might have something to say to you. Very similar in this context, right? As kind of going back to Christina's terminology, there are natural consequences to behavior. The benefit we have here is that we have a service provider who gets to come in and say, hey, what's going on with all these people you're having in? We're getting some complaints. And at some point, that complaint may elevate to the level where a person may be asked to leave. That's the same in any apartment building, right? And so it's a very similar process here. If you have more to add, Robert, please continue going. But that's my general perspective. Go ahead, John. I see your hand.
Just a quick comment on that. And I agree with everything Ryan has said. The other reason that, or thing I would point out is that one of the great reasons we went with Roof Above is that they have 700 other apartments around town, or almost 800 now. And so in an instance where Ralph in apartment 3 just isn't working out, we don't have to put Ralph back out on the streets. So in some cases, while we do want to practice high fidelity Housing First, Roof Above will work with us if we just, as Ryan and Melissa said, if we just can't solve the problem, there is a safety net for Ralph in terms of other properties. That's not going to be something we want to do often, but that's a feature of Roof Above that we were really pleased with.
Yeah, that's great. And that's not too dissimilar from our setup, where if a person is not being successful in a unit, they may lose that unit, which could involve them having to go back into a shelter for some time period. What we will try and do is rehouse them, but all along the way, there's a bunch of conversations about the decisions that led to the loss of that unit. And, you know, when folks are housed in our setting, we expect around a third of them, around 30% of folks actually will lose that first apartment. And I think that speaks to like the skill set of managing an apartment. Is it okay for me to have guests at all hours of the night or not? I think there's skill involved there. There's like social skill, but also just like apartment management skill. And we find that once we rehouse people through tons of conversation and wrestling with these issues, the number of people that lose that second apartment decreases by half, right? And so people do need the opportunity to do some decision making, to face some natural consequences, and hopefully in a Housing First type setting, we can rehouse them and give them another chance. And it sounds like maybe what happens with, you know, patient Ralph is they go to a different apartment building, and maybe somebody else gets to fill that slot here on campus. I see your question, Elena. Let me just touch on a couple quick things that I saw in the chat. Ben says, I'm curious about how you balance quote unquote no housing readiness requirements in Housing First with safety and security. Is there any kind of background check that would be consistent with Housing First principles? I think most of the folks that we're serving do have things that would run afoul of like typical background checks. And it's why they're chronically homeless in the first place. It is a different type of community that you're building than the one we have. I'll say that we need to be very clear about that. We're doing scattered site housing. And so we're not typically doing background checks like that. Did you have anything you wanted to add to that, Christina?
Yes, there is a background check done, not a traditional sense, kind of throughout the intake process. So after we've already received the referral, and there's kind of only two things to really note. Only one of them being kind of a factor that we could not accept somebody, and one of them, what we refer to as Megan's Law in the state of Pennsylvania. So someone who's a registered sex offender, they are still eligible to be a referral for Pathways, but that needs to be taken into consideration for their housing placement. And then the other is any arson. And that is just based on our ability with our HUD subsidies. Anyone with arson is kind of red X to not receive those services under that housing voucher. But any kind of criminal charges are by no means kind of looked at or investigated. That becomes that conversation piece of like, hey, you have these open cases. Do you want to help going to court and kind of addressing these things to reintegrate in the community? And then similar to that, I see Susan had asked a question, is it stated that no firearms are allowed on premises, or is that kind of not effective in any case? It is stated in the use and occupancy that we sign with our participants that no weapons are allowed on site. We're not searching anyone's belongings though, or kind of going through their move-in boxes. So in theory, anybody could have weapons, but official policy is no weapons are allowed. And if service coordinators and care managers kind of get reports in any threatening way that there are weapons, then that's kind of, there's natural repercussions. That's not allowed. And we have that larger discussion on what that means.
Part of that, by the way, too, is that because so much of the work of Housing First happens in the home, if a participant has a weapon in the home and our case managers are going into that home frequently, we're putting them at risk, right? So a tough one to navigate, one that does perhaps sometimes come up, but it is against our stated policy. Elena, I think you're next on deck. Did you want to add something?
Yeah, I really did want to add that I think our focus, you know, as a community, as the church, really needs to be on the fact that we are there to provide community. All the information about your services, about Housing First, about addiction, about, you know, following the rules of the community or whatever, are really, if I'm not mistaken, under the purview of Roof Above and any organizations that they're working with. So I think, as important as these questions are, and certainly we need to have the answers to them, I think we really need to keep in mind that that is not our job. That is not going to be our job. That is not going to be our responsibility. That's not to say that, you know, we shouldn't mention something that's disturbing to us or, you know, whatever. But I think we really need to keep our eyes on the fact that we as Caldwell have provided the building, Roof Above is providing services, and we as a congregation are providing community, a place for people who have not been in community for a while, or maybe ever, or not in a supportive community, that's what we're really there for, to give them the opportunity to just sit and hang out and be a regular person and not have anybody judge them or, you know, tell them what to do or whatever. We're just there for them to talk to and to learn from, and us to learn from them. I really think that we need to focus on that, because I hear a lot of, and maybe I'm wrong, but I'm hearing a lot of, you know, fear and apprehension and whatever. And I really think that we need to focus on the fact that we're working with organizations that know what they're doing, that have done this before, and we can rely on them to take care of some of the issues that we're so concerned about.
Thanks for adding that, Elena. I think that is really important. And I will push back slightly and say, in my life, I want to understand what's happening around me, and I don't want to give up all sort of critical reflection on what's happening around me when there are experts around, right? I don't want my doctor to not give me the info about my own health if it's a technical bit of info about my health, right? And so, yeah, I agree with you. And it's a struggle for us, I'll be honest with you, as Housing First University, Christina and I, to kind of navigate with you, like, what is the right information to share? I think it's great that Roof Above is an incredible provider and is going to handle these things. And I think there are going to be questions that come up along the way where you're like, are they handling this thing? I don't know. Do we raise this issue? I don't know. And so I think having the context to me helps you ask the right questions, hopefully. I don't know. Anything to add
Yeah,
there?
and one thing, yeah, that I hope that you take away is some of this, like I mentioned earlier, is about human behavior and kind of
Yeah.
applied behavioral analysis that we don't expect average community members to know. Right? I don't know what your career force is outside of this meeting, and so the kind of some of these terms and human nature may be unfamiliar to you. And as community members, you're really excited to do the work and be really good neighbors, but understanding why they're not engaging, in their first week or in their first month of being in Caldwell, I think is really important context here. Kind of that repetition, building that rapport as neighbors, and that consistency is what is going to help these 21 members really reintegrate into your community. But Elaine, I echo what you said about just listening to them. And I think John has said this, and as a congregation, and what you're good at is listening and being good neighbors. So I think that you guys have a big skill set there that you're just expanding on now with some of this context for this population.
And I think it's completely valid to ask these questions, especially because we don't know a lot about the process and about how things are worked out and screening and drug treatment programs and stuff. So I do think it's really important to ask the questions, but I'm just saying that, when we ask the questions and we get the answers, I think it's also important to keep in mind that, the answers are coming from the organizations that are going to help with those issues.
Yes.
So it's good to have the answer, but there are people who are going to be in charge of that. So.
Yep, that's great. John, did you want to add something?
I was just going to, share a blessing, compounded blessing. Liz Clayson Kelly, who's the CEO of Roof Above and has known Caldwell for 17 years of its revival, is thinking very hard about client selection. And so we will live within the definitions of housing first, but there are a lot of people out there who could fit within those rules. And so she's thinking very hard about 21 people who will fit in our neighborhood, on our campus, buy into the values and the philosophy that we're espousing. And earlier, Ryan and Christina mentioned Sam Simbaris, who's the grandfather of this movement. He is particularly and highly individually interested in giving us some ideas about how we choose those 21 people within the bounds of Housing First, within all of the outlines that Christina and Ryan have shared, but in a way that anticipates the community we want to create. And so, it's a little bit of, if your mother says she loves you, check it out. We're going to do our best on selection on the front end, and we're going to do our best planning around security and risk management on the back end, both ends.
I like it. All right, let me move us forward here. There's a lot of stuff that maybe is not necessary here. Here's one piece that I do want to share. In the comparison between what Housing First has to offer and what a different model has to offer, one of the things that we see is these treatment first type programs who allow you to come into the program as a result of your disability. That's what is like your eligibility, your substance use disorder, your mental health, your physical conditions, etc. Often what we see is that folks fail out of programs like that for the very reason that led them into these programs in the first place. And so I say that to say it may not be uncommon for somebody to be in abstinence-based recovery, join your community, and relapse, right? That would be par for the course in terms of what addiction can look like for people, or have a mental health crisis, right? Or have some major health concerns that like sort of pop up. That wouldn't be out of the question. And often what we see in other somewhat more traditional models of care is that folks lose their housing as a result of those events. And we have a hard time with that. And in fact, that's one of the reasons why we think chronic homelessness exists, right? So just wanting to contrast this approach that you all are kind of embarking on with Roof Above is one that gives chances and also doesn't hold people's housing over their head as a stick, right? Or as a reward for compliance. We're not in the business of compliance, really. With the caveat that, like, my neighbors hold me in compliance sometimes if I have loud parties, right? There is a level of compliance there, but it's more of a social compliance as opposed to a programmatic one. I don't have very many loud parties though, so no worries there. Some stuff here that you might find useful or interesting in the slides that I'm not going to read. I think let me just do these last two slides, and then if there are further questions, we can engage. In terms of program expectations for a Housing First program, there's not much, but these things are critical. Folks are expected to sign and adhere to a standard lease agreement, at least in our program. We do that a little differently where we are the leaseholder and our participants are like a subleaser for us. But the sublease mirrors standard lease agreement, right? Folks are expected and must agree to receive home visits. The work of care for people in a Housing First program happens in their home. And so when people don't agree to receive home visits, that's a non-starter, right? We must be visiting them in their homes, checking on the state of the unit, checking on the state of the individual. And so that wraparound care and support is a mandatory part of the program. And then lastly, and at least in our program, folks are expected to contribute income if they have it. Not all of our folks have it, but for the folks that do have it, they're expected to contribute. And there are tons of conversations when people stop paying that rent. And what does it look like? And you're not paying your bills. Your bills are going to get shut. Your utilities are going to get shut off. So that's a lot of the conversation that we're having, in the same way that somebody would have that conversation with me if I wasn't doing those things, right? Okay, here's our last slide. And this is just a summary takeaway. Want to re-emphasize that homelessness, co-occurring disorders, these things don't stem from individual moral failings. This solution that we've been talking about and that Housing First is going to implement with you, or Roof Above is going to implement with you, is a proven and measurable solution with very specific outcomes. It's highly individualized, which can be scary because we don't know how it's going to look for somebody. But I think it's going to look successful, given what I've heard. And it serves folks who have traditionally been considered not housing ready. We're saying, you know what? Everybody's housing ready. Let's get these folks a roof over their head, and let's figure out what the next step is in their journey. Housing First is going to seek to meet somebody's basic needs and then identify additional goals and appropriate supports along the way. That's what we have for you tonight. We've done quite a bit of questions and answers as we've gone so far. I think it's been great. You all are a very curious, inquisitive, helpful, supportive group. So I'm really excited for the updates about how your project is going. But let me open up the floor for additional questions and comments that have come up in the last few minutes, or that you're still wrestling with as we sit here today. Oh my goodness, we stumped them, Christina. This is it. We gave them all the info about Housing First, downloaded it right into their brains.
You guys are ready and excited for your 21 neighbors.
Yes.
I'd like to thank the two of you for an excellent presentation. It's just been outstanding tonight. Thank you.
Well, thank you for that feedback. We appreciate
Jeff.
that. You know what I just want to echo, and I think this echoes Elena's comments. I think it's okay if there's fear and apprehension. And I think I see some people that are saying, no, we're not scared. We're just curious. I think that range of experiences is incredible and amazing and human and just right on point, right? And so I hope if you're feeling fearful, we've offered some things to help you manage that, and you're gonna get a ton of support from Roof Above. And if you're just curious, I hope this was like interesting and informative to you, and we want to continue to be resources to you as you go on. One way that we're going to try and do that is we have a couple of follow-up info sessions that we're going to do. And these are going to be less teaching in nature, less didactic in nature, and much more kind of informal discussion, dialogue, and hopefully some role play about maybe some of the questions that you have. So look out for invitations, calendar invites on some of those dates as we move forward. So it's not the last time you'll see us. And maybe if you're marinating on questions now, there will be voice for that in the future.
Yeah, perfect. Cue up, Ryan. We will have these friends back probably in the fall. The closer we get and the more specific things get ironed out this summer, a team will be sitting down specifically with Roof Above and ironing out any details, again, within the parameters of the program as it's been described. Dot Killian is going to take point on our congregational prep, which we're going to be calling Our Neighbors Ourselves. So this curriculum that we've been doing will get kind of rebranded. So if you see Our Neighbors Ourselves in the future, that means more workshops and things. This summer, we'll probably be doing some poverty simulations and some maybe some trauma-informed care workshops. So Housing First University has been immensely helpful in these April and May sessions. We will come back to them in the fall. We will hear from other experts over the course of the summer. And I echo the feedback. Y'all have been terrific. Thank you.
Thanks so much. Just wanted to shout out that I dropped the link to the course eval in the chat. I'll follow up with an email too, if that's helpful. Would love your feedback, including critical feedback. We take that all very seriously. But I'll say thank you so much for spending these 2 hours with us. It's been a pleasure for us. I hope you have a great rest of your night.